Hi guys, so today we are going to cover hypokalemia from Toronto Notes. It is an important topic. So hypokalemia is potassium levels of less than 3.5 milliequals per liter. Usually it is asymptomatic, but patient may present with nausea, vomiting, fatigue, generalized weakness, myalgias, cramps, and constipation. In severe cases, patient may even present with arrhythmias, rhabdomyolysis, myoglobinuria, and may lead to respiratory impairment as well. And when a patient is presenting with arrhythmias, it is more likely when the patient is using digoxin or is hypomagnesemic or has coronary artery disease. Now, ECG changes with the hypokalemia are very specific and we need to know them. So, on ECG changes, we need to see for the U wave. U wave is more important, is the most important one, and there is low amplitude wave following T wave. So U wave is basically a low amplitude wave that is followed by T wave. And then there is also flat or inverted T wave. We can see in the picture there is a T wave, and after T wave there is another curve that is the U wave. Okay, and there's U wave formation, and then there's inverted T waves, there's depressed ST segment, and prolongation of QT interval with sinus bradycardia. In severe hypokalemia, it may present with PR prolongation, wide QRS, arrhythmias, increased risk of digitalis toxicity. Alright, and common arrhythmias seen with hypokalemia are ventricular fibrillation and ventricular tachycardia. Alright, let's repeat. So we see U wave most important, we see ST in depression, we see T wave inversion, prolonged QT interval, sinus bradycardia, in severe cases PR prolongation, wide QRS, arrhythmias, and the risk increases with digitalis. There's ventricular fibrillation and ventricular tachycardia. Okay, more common types of arrhythmias. Now we see the approach to hypokalemia. How do we approach a patient with hypokalemia? Let's say a patient comes in emergency with hypokalemia. We need to check their serum potassium levels. If the potassium level is less than 2.5, we need to obtain an ECG. And after ECG, we need to begin the treatment. And we need to rule out the transcellular shift of potassium as the cause of hypokalemia. Let's say in diabetic ketoacidosis, we need to see if the patient has DKA. And then we also need to see the contribution of dietary intake. And then we do spot urine potassium creatinine ratio. If the ratio is less than 1.5, that is GI loss. If more than 1.5, the reason is renal loss. And also we need to check 24-hour potassium excretion. If renal loss, we need to check blood pressure, acid-base balance status of a patient. We need to see the plasma renin, aldosterone levels, and serum magnesium levels. Now, on the right side, we see hypokalemia is often accompanied by metabolic alkalosis. That means then when there is a potassium shift from the cells to ECF, there is increase in hydrogen shift into the cell in response to potassium migration. Then there is increase in bicarb. The increase in bicarb causes the intracellular pH decrease. And then in response to low pH, there is more retention of hydrogen. Okay, and when hydrogen retains, there's more increase in bicarb in the plasma, which causes metabolic alkalosis. Okay, so the most important thing here to remember is with hypokalemia there is metabolic alkalosis. Why? Because the potassium shifts to the ECF, there's increase in hydrogen ions, which causes bicarb to increase, the pH decreases intracellularly, and then there is more hydrogen retention, which leads to more bicarb secretion in the plasma, which causes metabolic alkalosis. So metabolic alkalosis is associated with hypokalemia. Okay. Now we see the approach to hypokalemia. There are three causes we said: decrease intake, increased loss, or the transcellular shift. So in decreased intake, it could be because low intake, low dietary intake, or clay ingestion. In increased loss, we need to check spot urine potassium creatinine ratio. We discussed before that if it's less than 1.5, that means it's a GI loss, and if it's more than 1.5, that means renal loss. In GI loss, it could be diarrhea, laxatives, and villus adenomas. And renal loss, we need to check the blood pressure as well. If the patient is normotensive or hypotensive, then we need to check the acid-base shift. Okay, and acid-base shift is if the patient is acidemic, that means that DK is the cause, or renal tubular acidosis, variable hypomagnesemia or vomiting. And then if the patient is hypertensive, there could be primary hyperaldosteronism, Conn syndrome, secondary hyperaldosteronism, renovascular disease, or renal tumor. mineralocorticoid, that is Cushing's disease, exogenous aldosterone secretion. And then in alkalemic state, there are two conditions: diuretics, because of furosemide or thiazide diuretics, which may cause hyperaldosteronism, metabolic alkalosis, and increased flow of collecting duct, or an inherited cause that could be Bartter syndrome or Gitelman syndrome. In Bartter syndrome, the condition is most likely because like a furosemide-like effect, and Gitelman syndrome, there's thiazide-like effect on the symptoms. So this is a general approach with hypokalemia. Okay, so now we're going to revise this once again. Hypokalemia, it could be decreased intake, increased loss, or the transcellular shift. If there is decreased intake, we know that the patient has limited intake of potassium, or there is clay ingestion. Okay, and then increased loss, we need to check the potassium creatinine ratio. If it's less than 1.5, GI loss. If it's more than 1.5, it's a renal loss. If it's a renal loss, then we need to check blood pressure. Blood pressure is hypotensive or normotensive. We need to check the acid base status. If hypertensive, we know the two conditions. Okay. Okay, so if we are now checking the acid base status of the patient, if the patient is acidemic, we know the patient may have diabetic ketoacidosis or RTA. If there is a variable condition, we know that patient may be hypomagnesemic or vomiting would be the cause. And if the patient is alkalemic, we need to see the diuretic use or inherited renal tubular lesions like Bartter syndrome or Gitelman syndrome. In Bartter syndrome, there's dysfunction of loop of Henle, where like there's a furosemide-like effect. In Gitelman, there's a dysfunction of DCT, distal convoluted tubule. Now, the transcellular shift. The transcellular shift happens in metabolic alkalosis status, insulin, catecholamines like beta-2 agonist salbutamol, theophyllenes, tocolytic agents, and uptake into newly forming cells, vitamin B12 injections, in pernicious anemia, colony stimulating factors, increased WBC production. So these are the cause for the transcellular shift. So now we'll see how we will manage the patient with hypokalemia. So we need to treat the underlying cause. If there is true potassium deficit, we need to replace the potassium. It could be by oral sources or IV. In oral, we have options for food, tablets, KCl liquid solution. In IV, we have like KCl in saline solution, and we need to avoid dextrose solution because that may exacerbate hypokalemia while insulin release. Okay, so maximum is 40 millimoles per liter by peripheral vein, 60 by central vein, and maximum infusion is 20 millimoles. Potassium sparing diuretics can also be given like triamterene, amloride, and spironolactone, and we need to restore magnesium before we correct potassium. And if the urine output or if the renal function are impaired, we need to correct the extreme caution. We need to take the extreme caution. Risk of hyperkalemia with potassium replacement, especially high in elderly, diabetes, and decreased renal function. So in that cases, we may be using ACE inhibitors or ARB, especially for congestive heart failure, because that would reduce the aldosterone production. Okay, let's just rapidly revise. So oral is KCl liquid solution, IV is uh, KCl's in saline solution, and then the maximum is 20 millimoles per hour. Potassium sparing diuretics are triamterene, amloride, and spironolactone that can be given. We need to restore magnesium before correcting potassium. If renal compromise, and we need to be very careful. And the risk of hyperkalemia with potassium replacement, especially in in elderly, diabetes, and decreased renal function. In patient with congestive heart failure, for hypokalemia, we will give ACE inhibitors or ARBs because it would reduce angiotensin II action and would reduce aldosterone. And we have to be very careful for transcellular shift.